Imagine taking a pill to stop a seizure in your brain,
Right.
right? But then months later, you find out that the exact same medication is, well, it's actively melting the bones in your legs.
Yeah, I mean, it sounds completely absurd, like some bizarre medical urban legend.
Exactly. But it's actually a documented physiological reality. So whether you're prepping for your medical boards or, you're just insanely curious about how the human body works, you are in the right place.
Absolutely.
Today, we are doing a comprehensive deep dive into rickets. We're looking at clinical texts, diagnostic criteria, and treatment protocols to really understand the entire life cycle of this condition.
From the very earliest historical complaints all the way to the full treatment plans, yeah.
Right, because we want to figure out how a single missing molecule can cause the human skeleton to just structurally collapse. Okay, let's unpack this, starting with the fundamental definitions, because the sources make it really clear that a bone isn't just, a hard stick of calcium.
No, not at all. If you look at the fundamental composition of a bone, you're looking at a highly dynamic two-part structure.
Okay.
First, you have this organic framework. It's called the osteoid. And that's primarily made of protein, specifically type 1 collagen, which is secreted by osteoblasts.
Right, the bone-building cells.
Exactly. And then second, you have the inorganic mineral phase. This is predominantly calcium and phosphorus, and they crystallize together into something called hydroxyapatite.
So if the bone is a building, the osteoid is the steel
Right.
scaffolding, right? And the minerals are like the concrete.
That is a highly accurate way to visualize it, yeah.
In rickets, it's like the concrete never properly sets while the building is still under construction.
Right. The steel rebar, that collagen, it gives the bone its shape and tensile strength so it can flex a little. But without the concrete, it has zero compressive strength. It just gives way under the weight of gravity.
And this brings up a really crucial distinction from the source text. It's something that frequently trips people up, the difference between osteomalacia and rickets.
Yeah, that's a huge point of confusion.
Because both involve a failure of that concrete to
Yeah,
set.
they do, but the distinction relies entirely on the biological timeline of the patient. Osteomalacia is the inadequate mineralization of the osteoid that happens after the growth plates have fused.
So that's mature bone.
Right. It happens in both children and adults. It's a generalized softening. But rickets, specifically, is the non-mineralization of the bone matrix occurring right at the epiphyseal growth plates before they fuse.
Meaning the building is actively under construction.
Yeah.
The osteoblasts are furiously laying down this new steel rebar to lengthen the bone, but the concrete just never arrives.
Exactly. And because that cartilage at the growth plate never calcifies, it doesn't die off like it's supposed to.
Oh, wow.
Yeah, the cells just keep multiplying. It causes the growth plate to expand erratically. So the structural integrity is just compromised from the very first millimeter.
To understand why that concrete fails to set, we have to look at the master contractor of bone building, which is vitamin D, which takes us to the incredible journey this vitamin makes through the body.
It really is an incredible relay race.
Right, because looking at the literature, naturally occurring dietary sources are shockingly sparse. You've got, what, cod liver oil, egg yolks, some fatty fish.
Basically, yeah. It's a highly restrictive diet for humans to rely on naturally.
Which is why industrialized countries intervened, right? They started fortifying staples like cereals, milk, and salt.
They had to. But dietary intake was only ever meant to be a backup system. The primary physiological factory for vitamin D is internal.
Starting with the sun.
Right, the factory line starts in the skin, specifically with ultraviolet B radiation from sunlight. When UVB rays strike the skin, they interact with a precursor molecule there called 7-dehydrocholesterol.
And it literally breaks the molecule apart.
Yeah, the energy from the photon physically breaks a carbon ring, converting it into pre-vitamin D3, which then isomerizes into vitamin D3 or cholecalciferol.
But the skin is just the starting line. It has to travel from there.
Exactly. It gets picked up by a specific transport protein called vitamin D binding protein, and that taxi carries it straight to the liver.
Why the liver? Like, what is the hepatic system actually doing to this molecule?
The liver acts as the first major processing plant. It uses an enzyme called 25-hydroxylase to add a hydroxyl group to the molecule.
Okay.
So now it becomes 25-hydroxycholecalciferol or calcidiol. This is the main circulating form in your blood. When your doctor checks your vitamin D levels, this is what they're measuring.
Right, because it's stable and has a long half-life. But the texts emphasize it is still completely biologically inert at this stage, right?
Correct. It can't force the gut to absorb calcium yet. It has to get back in the bloodstream and travel to the kidneys.
The final checkpoint.
Exactly. In the kidneys, a second enzyme, 1-alpha hydroxylase, does the final molecular tweak. It adds one more hydroxyl group.
Transforming it into the active component.
Yes, 1025 dihydroxycholecalciferol, or calcitriol. This is the fully active, highly potent steroid hormone. What's fascinating here is how selectively this active component facilitates mineral absorption in the gut.
Yeah, the sources make a huge point about this regarding phosphorus versus calcium.
Right. Phosphorus absorption is not entirely dependent on this active hormone, but calcium absorption, it relies on it entirely.
Without that active hormone from the kidney, calcium absorption just hits a brick wall. You can drink milk all day long, but it just passes right through you.
Exactly. Your absorption drops to maybe 10 or 15% of what you consume, and your body cannot tolerate a drop in blood calcium.
Which brings us to the feedback loop, the body's internal thermostat for these minerals, involving the parathyroid hormone, or PTH.
The parathyroid glands are constantly sampling the blood. When active vitamin D is high or your calcium levels are normal, this negative feedback mechanism suppresses the secretion of PTH.
The thermostat reads normal, so the furnace stays off.
Right. But the second that serum calcium drops, because the gut isn't absorbing it, the parathyroid glands detect the deficit instantly. They flood the bloodstream with PTH.
And PTH has one mandate, right? Get calcium back into the blood at all costs.
Yes. And if it can't get it from your food, it goes to the skeletal bank. It triggers the osteoclasts to actively dissolve the hydroxyapatite concrete of your bones to release calcium back into the blood.
So we have a perfectly balanced, highly complex supply chain relying on the sun, the liver, and the kidneys. But what happens when there's a roadblock in that chain? Let's look at the saboteurs, the myriad of ways this process can fail.
There are quite a few, starting right at birth.
Right, let's talk about nutritional and exposure deficits. The assumption is usually that breastfeeding provides everything an infant needs.
It's a huge misconception in this specific context. Breast milk is surprisingly deficient in vitamin D. It only contains about 1 to 4 micrograms per liter.
Wow, that is statistically nothing.
Exactly. So if an infant is exclusively breastfed without any supplementation, they are highly susceptible to severe demineralization.
And that risk is just exponentially magnified for preterm babies, isn't it?
Yes, because vitamin D and calcium are normally deposited across the placenta during the 3rd trimester of pregnancy. If a baby is born at 28 weeks, they physically miss that metabolic payload.
They start with a completely empty bank account.
Yeah.
And even full-term babies have environmental hurdles, like melanin.
Right. Darker skin pigmentation acts as a highly effective natural UV filter. It absorbs the UVB radiation, which directly decreases the skin's ability to synthesize vitamin D from the sun.
Which is why pregnant women, especially those with darker skin living in northern latitudes, really need adequate sun exposure or supplements early on.
Exactly. If the mother is deficient, the infant will be deficient.
Okay, so those are nutritional and exposure saboteurs, but you can have perfect diet and sunshine, and the system still crashes if you have an internal malabsorption issue.
Because vitamin D is fat soluble, so it requires an intact gastrointestinal and biliary system to be absorbed. If a child has liver disease or a GI disorder like celiac, they can't absorb dietary fats properly.
So the vitamin D just stays trapped in the unabsorbed fat and gets flushed out.
Exactly. Liver issues block the absorption of all fat-soluble vitamins, so A, D, E, and K. And beyond just malabsorption, actual organ failure actively breaks the physiological chain we talked about earlier.
Right, because if the liver fails, you knock out the 25-hydroxylase enzyme.
Yep. And if the kidneys fail, you knock out the 1-alpha hydroxylase. The factories are literally shut down.
Which brings us back to the hook from the beginning. It makes sense that kidney failure affects bones, but the sources specifically mention seizure medications. How do those connect?
This is a wild pharmacological interference. Anticonvulsants like phenytoin sodium and phenobarbital actively degrade vitamin D.
Like, why does a brain drug destroy a bone vitamin?
Because those drugs are metabolized by the liver. When a patient takes them, the liver ramps up production of specific cytochrome P450 enzymes to clear the drug. But those exact same enzymes also actively catabolize or destroy vitamin D and its metabolites.
Oh, wow. So the liver's just working overtime, and it ends up chewing through the body's vitamin D stores.
Exactly. And there are other drug interferences too, antacids containing aluminum, for example.
Wait, really? Just normal antacids?
Yeah, the aluminum actively binds to phosphate in the gut, forming an insoluble complex. So it actively interferes with phosphorus absorption, starving the bones of that mineral.
Because there are so many ways this system can fail, from a lack of sunshine to taking antacids to liver disease, the clinician has to act like a detective when a patient presents with symptoms.
You really do. Taking the history is critical.
Let's decode those presenting complaints. When you're doing that detective work, you're asking about the pregnancy, sun exposure, any history of seizures indicating anticonvulsant use.
Right. You're hunting for the specific point of failure in the supply chain. You're asking about malabsorption issues, pale stools, things like that.
Here's where it gets really interesting, though. The clinical texts emphasize looking at urinary features.
Because the kidney is that final crucial factor.
Right. Doctors are looking for decreased urine output, abnormal urine color, blood in the urine, or specific dipstick reactions.
Exactly. If you see those features, you immediately pivot away from a simple nutritional deficit. You start looking for primary renal failure or genetic disorders affecting the kidney.
You're trying to pinpoint exactly which factory is malfunctioning. And once the history gives us that context, the physical examination reveals the structural damage.
And it is profound structural damage.
Because rickets happens before the growth plates fuse, right? So the physical signs are systemic. Let's do a head-to-toe examination based on the sources, starting with the head.
The classic infant sign here is craniotabes.
The ping-pong sign.
Yes. When you press on the flat bones of the skull, usually the occipital or parietal bones, the bone actually dips inward and pops back up, just like pressing on a ping pong ball.
Because the osteoid is there, but it hasn't calcified, so it's just soft and pliable.
Mm.
But the texts, like Nelson's guidelines, are very clear that you can't just feel a soft skull and immediately diagnose rickets.
No, you have to run through critical differential diagnoses. You have to consider osteogenesis imperfecta, which is brittle bone disease.
Right.
You also have to rule out syphilis, which can cause bone lesions that mimic the softening. And crucially, you have to check for hydrocephalus.
Which is the buildup of cerebrospinal fluid. But how do you tell the difference clinically between a rickets skull and a hydrocephalus skull?
Hydrocephalus presents with severe craniofacial disproportion. Because the fluid is accumulating inside, the entire head balloons outward.
Making the face look tiny in comparison.
Exactly. In rickets, you don't have that internal fluid pressure. Instead, you see something called frontal bossing.
Which is a prominent swollen forehead.
It-
The texts note that frontal bossing is also seen in sickle cell anemia, right?
It is, yeah. Though in rickets, it's caused by the excess uncalcified osteoid piling up at the front of the skull. You also see delayed dentition teeth coming in late, and sometimes alopecia.
Okay, so moving down to the chest, this is where the skeletal deformities start to impact internal organs. The texts describe ricketic rosaries,
Yes, these are enlarged costochondral junctions along the ribs.
the growth plates of the ribs.
Exactly. As the cartilage expands but fails to calcify, it creates these prominent bead-like bumps all down the chest wall. It physically looks like a rosary under the skin.
And right below that, you have Harrison's sulcus or Harrison's groove, which is this horizontal depression along the lower edge of the ribs.
If we connect this to the bigger picture, Harrison's groove is a terrifying mechanical failure. It happens right where the diaphragm attaches to the ribs.
Because the diaphragm is pulling inward every time the child breathes.
Right. Normally, a rigid rib cage acts as an anchor. But because these ribs are so soft, the sheer force of the diaphragm pulling continuously inward actually buckles the ribs. It carves a permanent groove into the chest.
Wow. And the weakness of these chest muscles, combined with that deformed rib cage, it doesn't just cause a groove, it actively predisposes the child to severe respiratory issues, right?
Absolutely. They can't expand their lungs fully, and they can't generate a strong cough. So they are incredibly prone to pneumonia and recurrent respiratory tract infections.
That's horrifying. So as we continue down to the extremities and the spine, we see the bony deformities related to weight bearing. There's a widening of the wrists and ankles.
Again, that's the unmineralized cartilage just piling up at the joints.
Because of the poor mineralization, the bones simply give way when pressure is applied through normal infant activities, like crawling or standing.
The physics of the child's weight literally dictate the deformity. If the weight pushes outward, you get genu varum, which is severe bull leg.
And if it pushes inward, you get genu valgum, the classic knocked knees.
Right. You can even see windsweep deformities, where there's verum on one leg and valgum on the other, so the legs look like they were blown sideways.
Or genu recurvatum, where the knee actually hyperextends backward because the bone can't handle the vertical load.
It's devastating. And systematically, you see failure to thrive, extreme listlessness, restlessness. You see delayed walking milestones, obviously.
Right, because how can you walk when your bones are bending like rubber? And the spine is affected too: scoliosis, kyphosis, lordosis.
Plus the muscular issues. Because of the hypocalcemia, you get severe muscle weakness. That's why you see a protuberant potbelly abdomen. The abdominal muscles are too weak to hold everything in.
And if that calcium drops low enough, you hit tetany.
Yes, spontaneous muscle cramps and spasms because the nerves become hyperexcitable without enough extracellular calcium.
Seeing these physical signs is shocking. But to confirm the diagnosis and tailor the treatment, we have to look inside the body through labs and x-rays.
The blood work tells the exact biochemical story.
Let's decode that blood work. The expert methodically breaks this down. What does the typical lab panel look like?
Okay, so first, calcium is going to be low.
Makes sense.
Phosphorus will usually be normal or low, and the parathyroid hormone, PTH, is going to be incredibly high.
Because of that feedback loop, trying to compensate, the parathyroid is just screaming at the body to find calcium anywhere it can.
Exactly. Next, you look at the 25-hydroxycholecalciferol, the liver metabolite. That is usually low. And the alkaline phosphatase, or ALP, is usually very high.
Because the osteoblasts are working overtime trying to build bone, spitting out ALP in the process. But what about the active hormone, the 1,25-dihydroxycholecalciferol?
This is a major clinical nuance. The level of that active hormone can actually be low, normal, or high, depending on the root cause.
Wait, how can it be high if the patient has rickets?
If the patient has a renal condition like Fanconi syndrome, which damages the kidney tubules, then the active hormone will be low because the kidney factory is broken.
Okay, that tracks.
But if they just have inadequate calcium or vitamin D intake, but their kidneys are perfectly healthy, the massive spike in PTH forces the kidneys to work at maximum capacity.
Oh, so the kidneys aggressively convert whatever tiny amount of precursor they can find into the active hormone.
Exactly. So the active hormone levels might look totally normal or even high just because the kidney is in total overdrive trying to fix the starvation state.
That is fascinating.
Yeah.
Now, looking at the urinary findings, the sources mention that urinary calcium is appropriately low, but urinary inorganic phosphorus excretion is high. If the body lacks minerals to build bone, why is it actively dumping phosphorus into the urine?
It's a great question, and it's a key insight from the text. When calcium is low in the blood, its binding with phosphorus is also low.
Right, they usually bind together.
So you end up with more unbound free phosphorus circulating, and on top of that, the massive PTH spike we talked about earlier actively forces the kidneys to excrete phosphate.
Why would it do that?
Because if PTH is pulling calcium out of the bone, it's pulling phosphate out with it. If both spike in the blood at the same time, they'll crystallize in the soft tissues and blood vessels.
Oh, wow. So dumping the phosphorus in the urine is like a protective mechanism.
Exactly. So you see high urinary phosphorus.
Okay, so the labs confirmed the total breakdown of mineralization, and the radiological assessments actually visualize it. What do we see on an X-ray?
You're mainly looking at the epiphysis, the growth plates. You'll see cupping of the bones.
Or the end of the bone looks hollowed out, like a cup.
Yeah, because the soft cartilage is bulging outward.
Yeah.
Then you'll see fraying, splaying, or broadening of the bone edge. It looks fuzzy, not sharp.
Like a frayed rope.
Exactly. And the most striking feature is rarefaction.
Which is a decrease in bone density on the film.
Right. Because the dense mineral concrete isn't there, the X-ray beams pass right through the bone. It literally increases your ability to see through the bone on the image. It looks ghost-like.
We have the history, we see the deformities, and the labs and X-rays confirm everything. Now, how do we rebuild? Let's get into the full treatment plan.
The medical intervention is aggressive. The absolute mainstay of treatment is the administration of vitamin D, obviously.
But alongside adequate intake of calcium and phosphorus.
Yeah.
Right. You can't just give the blueprint without the building materials.
Exactly. You have to provide all of it. And the dosages are very specific.
Mhm.
To aggressively correct the deficiency, clinicians prescribe 2,000 to 5,000 international units of vitamin D daily.
And they run that massive loading dose for a period of 4 to 6 weeks.
Right, to completely saturate the body's stores and get the factories running again.
But then comes the maintenance therapy. And the texts emphasize a crucial note here. Once you finish that 6-week corrective phase, you drop down to oral 400 IU daily for infants under 1 year.
Or 600 IU daily for children over a year old, yeah.
But this maintenance is for life.
Yes, that is non-negotiable. If the underlying environmental or genetic factors haven't changed, like their latitude or skin pigmentation, the disease will just come back if you stop supplementing.
So what does this all mean for a patient who might not take their medicine every day? Because we're talking about asking a family to administer a daily oral medication for the entirety of a child's developmental life.
It's a massive socioeconomic and compliance hurdle. Statistically, daily adherence is incredibly difficult for many families.
Which brings us to the pre-hospital or compliance solution outlined in the sources, STOS therapy.
STOS therapy is brilliant. It's designed specifically for suspected noncompliance.
How does it work? I mean, STOS means to push or shock, right?
Yes. Instead of relying on a daily pill for weeks, you administer a massive dose of 300,000 to 600,000 IU of vitamin D.
Wait, 500,000 units?
Yes, divided into 2 to 4 doses, all within a 24-hour period.
How is that not instantly toxic? Doesn't that cause massive hypercalcemia?
You would think so, but vitamin D is fat-soluble. So when you administer that massive shock dose, the body's adipose tissue, the fat cells, instantly absorb and sequester the excess.
Oh, so it locks it away.
Exactly. It acts like a biological time-release capsule. The fat slowly releases the vitamin D back into the bloodstream over the next few months.
That is incredible. And then they follow that up with the standard daily oral therapy just as a baseline.
Right. But even if the parents miss a week of doses, that deep reserve in the fat tissue keeps the child safe. This raises an important question, though, about how medical protocols must adapt.
Yeah, adapting not just to the biology of the disease, but to the social and behavioral realities of the patient. STOS therapy perfectly bridges that gap.
It really does.
Well, looking back at everything we've unpacked today, it really summarizes the incredible interconnectedness of the human body.
It's staggering.
I mean, how a little bit of sunlight, a healthy liver, and functional kidneys all have to work together in perfect harmony just to allow a child to crawl without their bones bending.
The mechanism is just exquisitely balanced.
It is. Thank you so much to everyone listening for taking this intensive journey with us through the clinical landscape of bone mineralization.
We covered a lot of ground today, and I want to leave you with a final thought to ponder, something that really builds on these clinical texts.
Go for it.
We discussed how heavily we rely on the sun and fortified foods to trigger this complex internal factory, right? It makes you wonder, as human beings continue to migrate toward highly industrialized, indoor-exclusive lifestyles, moving further away from the equator, constantly wearing sunscreen, living behind UV-blocking glass,
Yeah.
are we fundamentally outstripping our own evolutionary blueprint for bone growth? And what new modern interventions might be required for the generations to come just to build a functional skeleton?
Man, that is a profound question. Something to really mull over. Well, keep questioning, keep exploring, and we will see you on the next deep dive.